Now it's my pleasure to introduce our keynote speaker, Dr. Eric Goosby. Dr. Goosby is a professor of medicine at the University of California, San Francisco School of Medicine, and a former United Nations Special Envoy on Tuberculosis. Over to you, Dr. Goosby.
Well, thank you very much, Casey. I want to thank you and Jonah for the kind invitation to speak to you and your colleagues today. I think this is a remarkable time that we all find ourselves in, having been in front of the COVID outbreak and trying to orchestrate responses that take multiple divergent resources, funding lines, human resources, as well as trying to manage different geographic outbreaks in terms of intensity, with an eye to equity and kind of compassion in how we roll those services out. We've all been through the national, state, and local responses domestically, and internationally have had to learn to understand how donor resources come into countries, marry, match, synergize, or don't with domestic resources in international work, and how foundation and research efforts can be woven into a local response to look for opportunities to strengthen it. That requires a huge amount of surveillance to understand what you and the outbreak are doing at any point in time in any given geography, and to move that information into decision-making that allocates resources, both human and drugs, as well as testing capabilities, et cetera, that have a distribution challenge, both at a city and a state level, that really continues to present barriers to accessing both testing initially and now with vaccination effort with the COVID. So let me just go through the first slide, please. The next slide. So we're going to look at the critical role as we were just hearing from Casey, that the concept of One Health plays in helping us to understand the need for a more open and orchestrated awareness of not only how resources move, but how delivery systems are better or less interfaced with given populations at risk or our target populations. And that intimacy of understanding of how delivery systems do or don't interface with populations really was a huge challenge for both HIV, TB in the global sense, but for COVID that we have just all gone through. So our ability to improve our surveillance so we are aware of an outbreak, the need for that surveillance to inform a system that allows for preparedness to be informed and expanded, and the ability to detect and tailor a response to the specific needs of that population suffering from the outbreak becomes a recurring, repetitive challenge. And in San Francisco and California, looking at different areas in the state, we had huge differences in what the response capability could be. And coming to a level of awareness of that to activate us was a large challenge for all of us. And I think we saw that reproduced virtually everywhere. I think that the prevention strategies that come up become informed by the first understanding of what the quote problem is, but the surveillance needs to continually feed in to decision makers, policymakers, so corrective action can be instituted in as real time as possible. Next slide, please. So animal, human, and environmental health, 60% of infectious diseases arise from pathogens in animals. Our paradigms for addressing the zoonotic disease outbreaks have historically largely been reactive. Our ability to understand where a surveillance system would be needed and most effective is impaired. We do not have that mapping. And looking, once we've identified a potential threat, looking at that threat over time to see how it changes is more of an aspiration than an actual capability. The economic losses that we've seen from any outbreak, but most specifically the COVID outbreak, has been breathtaking. SARS cost $50 billion despite a 9,000 person impact. COVID-19's impact is ongoing, and still we have not reached that zenith. I think looking at the economic impact as we move out year by year, travel and entertainment, hotel type impacts, as well as the extraordinary impact that's occurred with airlines. Next slide. So animals consume 2 times for the AMR issue that we have all looked at, especially in the context of tuberculosis, and see that our ability to appreciate the drive for antimicrobial resistance sits with our colleagues in the animal industry. The understanding of that, I think, has evolved, and I believe we are now at a point where taking that data and reflecting it back into policy decisions needs to be part of where we go with this. Our consensus around our ability to stand up a surveillance capability through the international health regulation in particular is something that I think we need to be honest about. The next slide, please. In its inability to allow us to monitor and understand where outbreaks are, especially in countries that do not have a surveillance system that is running continuously, that is uniformly covering the geography. We still are largely dependent on multinational NGOs who are in the area to highlight an outbreak. And that is something that we have talked a lot about since the Ebola challenges in 29 to 14, but have not pivoted into a effective, sustainable surveillance system, even though it is well described in the IHR 2005. I think as to highlighting these issues, animal reservoirs in which we have a jump that occurs, we are dependent on colleagues who are aware of different patterns in the population, highlighting the potential for the first time we see a threat is being when that individual infected presents themselves to the medical delivery system. This is long after the opportunity to embed and spread has occurred, and we need to put our surveillance system in front of a pathogen as it begins to move into the population specifically. Very hard to do, but we need to be able to mobilize our resources to get in front of it rapidly. Next slide, please. So the One Health idea, detection, response, and prevention, coming from a global, national, and local level. The rest of the conference exchange will highlight examples of this kind of orchestration that is multi-sectorial, transdisciplinary, does a transparent collaborative effort is critical to sustain it, and allow for an element of accountability, not blame, but accountability to be part of the integrity of the system. We need to be able to reveal weaknesses and vulnerabilities that is not met with criticism or ridicule, but with a attempt to better understand and strengthen the response. And I believe that is part of our shared responsibility as a global community. And it's the only realistic way, because of the disparities and maldistribution of capability throughout the globe, that we need to take that shared responsibility seriously, for the sake of everybody's ability to be alerted and prepared to strengthen a response to an emerging threat. The assumption that individual sovereign nations can take that entire complement from outbreak to response and not have a regional and global support to that is less of a response, and I believe would not be as successful. And I think we've seen multiple examples of that in our attempt to mount different COVID responses regionally. Next slide. So 60% of human disease arise from pathogens shared with wild or domestic animals. Risks are not limited to low-income countries. These risks can be identified virtually wherever you look. The idea of starting a surveillance detection capability that begins by focusing further out before it reaches domesticated animals and approaches a jump opportunity into humans is the surveillance system that we need to aspire to and create, and most importantly, sustain. I think the ability to maintain the will to continue to fund and support that level of global orchestration is something that's being discussed both at WHO and the UN system, but the Biden administration is taking this very seriously to try to convene a more specific discussion about the threats and who can respond to them from a regional perspective. So that discussion, for the first time in my career, is starting to bubble up. And I would say if the Biden-Harris administration is able to sustain interest, which it has now, in appropriation discussion, we will see if this pivots into a funded, sustained priority. But I believe the administration is trying to tee that up right now. Next slide, please. So improving detection demands new global action. The COVID realities have been, I think, in front of us for the past year. We've briefly talked about the IHR system's weakness, a system that speaks to a surveillance capability that is able to discern an outbreak, notify authorities, and have that concern quantified and moved to a WHO kind of announcement, evaluation, reconsideration of whether or not this really reaches an emerging threat level. That should release resources that converge on the site in such a way that the ability to stand up surveillance capability in a continuous manner that is present in the country begins to feed and inform an international understanding of it, with arrows going in both directions to rapidly expand needed capability expansion in the source country from the get-go. And that requires a regional ability to move resources to the problem and not have to reproduce capability in multiple areas that will, not be challenged to engage. So having somewhat of a Rolodex of talent that is regionally identified, that when an alarm goes off, can mobilize in hours to assess and report back and initiate an infusion of additional resources to either better define or respond to what they find. That commitment, I believe, is total and must be a shared responsibility. We have attempted to rely on individual sovereign nations to complete that continuum of services and capability around surveillance, and it has largely not been successful. And I know this is an area of real focus. To incentivize that surveillance capability is something that is being talked about now. I think this convening would have real thoughts as to what might be an incentive. We have gone back and forth with what that might look like, and I think is going to be a real area to unpack and further define. The connection to health security in most of the developed country settings is a resource motor for resources, additional resources that can augment and complete the need that we are seeing in detection at a global level. I think that governments and appropriators understand the need to respond with funding when it moves into a security context. This is something that medical people don't feel comfortable with. I know are not used to talking to security decision-making groups. They are not sensitive to a lot of the what I would call public health and medical considerations that come into play depending on the disease and the pathophysiology of the disease. I think public health people maybe overthink that those specifics are informing what to do. And I have been gratified to see security thinking really enhance the public health thinking and vice versa. So I remain optimistic about the marriage of this, but they're two very different cultures that come together, and it needs to be actively thought through as to how they set up a discussion for synergy. So next slide, please. So the detection demands new local action, without a doubt. It has to evolve locally, but to create a blanket of surveillance that covers everything for everything is unrealistic, not doable. So we need to be more sophisticated about this. And I know that many of you and your colleagues are looking at what are some of the different surveillance challenges that would make sense for earlier detection and an alarm system that alerts regionally, but gains and gets capacity support globally. That kind of partnership needs to be defined and developed. A lot of work with kind of big data, with looking at trends that have been very helpful in the COVID in understanding interactions with people, movement of people, how purchases are made in a given geography in California has really predicted where we see bumps in number of new cases and hospitalizations that follow. We've gotten very good at being able to predict what kind of onslaught hospital delivery systems are going to look at after periods of convening, like the Christmas, New Year period, et cetera. Those types of things on a global level are the same challenge. And I really think that using cell phones, purchasing patterns, movement patterns is something that really is going to add another lens to our ability to be specific and anticipate threats. Next slide, please. So the response, many countries have limited, as we have said, contact tracing capability as an example in COVID and TB. Our ability to push down the number of new cases, so case finding rekindles as a useful tool, is our goal. We have come in the last few weeks a long way to seeing that on the horizon. We're still probably 6 weeks away from it, but getting those numbers down will reinvigorate the utility of a case-finding contact tracing strategy. In the Bay Area in California, we have been very aggressive at standing this up. And when the numbers were high, it was not effective, obviously, but now we are beginning to see it come back. And our hope as we do the reopening in the Bay Area, we're doing it on 6 counties, not just with one city. And so we're doing a regional reopening, and we're going very slowly with surveillance informing each step of the reopening in a way we haven't done in the past 3 surges. So I think an example of shared responsibility and of a regional response, and I believe that globally that's the pattern we need to start modeling and standing up. Next slide, please. So this is really just a summary of the different sectors that need to be engaged in a continuous and in an episodic way. National governments in responding to outbreaks remain the entity that is responsible for the response and has a line of accountability that we can invoke. They are responsible for the population in a way that the other sectors are not, and I believe need to be held to playing that convening, orchestrating role because of that accountability. So governments, local, state, provincial, national, are critical at the convening level and are critical at the orchestration of most procurement distribution systems at scale. So they are a necessary partner. The next one I would say is understanding the critical role civil society plays in credibility to the communities that you're trying to embrace in services, or in giving you access to populations that are historically difficult to interface, identify, and retain in care over time. These community-based organizations have already done that hard work, and for us not to take advantage of that is a mistake. So civil society is a critical partner early on in the convening discussions. I see the academia as the natural partner to government for specific skill sets that are needed to stand up one capability or another, but also to take the data that is collected, aggregated, and rarely analyzed. That analysis is critical to stand up and create feedback loops that go back to policymakers, allocation decision makers. So mistakes in the implementation that has occurred in year 1, in year 2 can be better understood and modified. So you get and create self-correcting systems. That partnership between government and academia, local academia, not academia coming from 10,000 miles away only, that helps, it's important at times, but it is not a sustainable pattern. We hold it too long, and we need to pivot into finding that talent in a regional sense. And it is now largely in place after 30 years of responding to other epidemics such as HIV, TB longer than that. There are pockets of capability in all of the countries I've worked in that need to be recognized and expanded. Doing it that way, as opposed to bringing a academic medical center in from 6,000 miles away to stand up a capability, is another model, but not a model that we should look at as the dominant model. I believe we need to evolve and mature in how we deliver this type of care. Finally, the private sector, we constantly turn to public-private partnerships. I think appropriately, but we should not look at a public-private partnership as something that will sustain a response. They do not have a mandate. They never hold that mandate, or very rarely. And it's hard for a government to hold them accountable if they choose to recede their support. So should play the role. You should think about the role that makes the most sense for them. If it's a check writing capability or a capacity that they have in their private enterprise that you can piggyback onto, especially in procurement distribution type activity, they're terrific with that, and mid-level management. Those types of systems, they can help you stand up. The health diplomacy and advocacy is realizing the importance that One Health concepts and health delivery in general for governments dealing with one another, that global health programming plays a role in the diplomatic discourse between countries for the good, for the greater good. And the United States is trying to better understand how to be more aggressive in using a health diplomacy platform to discuss expansion of capability at the country level in kind of global programming priorities. So I think that this is an area that many countries in Europe are now understanding is something that needs to be leveraged more aggressively. The next slide. The prevention element is hard to anticipate. It's based on a strong eyes and ears, the surveillance system being the critical piece that gives us the ability to mount a counter response. The role of community health workers, the role of primary care becomes a final destination in all of these discussions to stand up silos of excellence in one disease process makes sense, but it doesn't make sense to stop there. That should be a bridge to a more integrated, sustainable portfolio of services that same individual with the one disease, HIV, TB, COVID, has other diseases that are creating morbidity and mortality in them that we as healthcare delivery system supporters need to acknowledge. So these centers of excellence, these one clinic that does one thing for one person, the demand it puts on an individual patient to move from family planning to HIV to TB care and try to find some primary care for hypertension, diabetes, and coronary artery disease along the way never made sense. But we never matured our programs to match the needs that were always there of the patients we engaged with and took responsibility for in that one disease focus. So I see this universal health care, the One Health concept as converging on what I believe is a global example that COVID represented to us as a global health community, the challenge we have in taking care of the needs of the people that are already in front of us, already known to our delivery systems, as well as be in a position to expand to a new threat. The next slide, please. So I think I really liked the CDC's, the collaborating, communicating, coordinating visual from kind of survey interviewing that they've done. Any crisis that threatens the globe, we really have seen another example through COVID of that shared responsibility, both in understanding the morbidity, the inequities as it moves through the population and has disparities and impact. As quickly as we can understand that and speak to it, we gain credibility with our populations. And if the understanding of differences in movement through populations is reflected in different allocation decisions, we continually gain credibility in the eyes of the population. That connection, especially in international work, is very hard to achieve and especially to sustain. But I just throw it out there as the challenge. For so many countries, the option of acting alone and expect for that to achieve what's needed is not realistic, and again speaks to the need for a WHO, UN orchestrated ability to identify unmet needs and to invoke the shared responsibility that we have as a global community to fill those unmet needs. We need to create a conduit where that can be presented, concretized, documented, and a line of accountability can be created. And I really think that the One Health platform is going to become more and more important to achieve that. So I think I would like to end there and open it up for questions or comments. I want to tell you that it was a real privilege to think about this in a way that I normally am not asked to do. So I thank the organizers for having that forethought. Thank you again.
Thank you, Dr. Goosby, for an excellent presentation and kicking us off with the keynote for this virtual workshop. I would like to remind everyone that you can use the Q&A box located along the bottom edge of your live video window to submit questions. You won't see that Q&A box if you're in full screen, so you need to leave full screen to be able to submit a question. So we have a number of questions that are coming in, and I would like to start off just asking Dr. Goosby a question regarding a little bit different than what he talked about, but given his role at an academic medical center, if he can tell us a little bit about what he might do to engage students in One Health.
Sure, Casey, that's, I think to me, talking to medical students, early on, and residents and fellows are all fair targets in trying to promote this thinking. They are the future of this gaining the traction that I believe it needs to play the role that it can. I think that students intuitively see this, but in each of the times that I've, like just in general medical rounds on general medical wards where general discussion on a patient may come up, bringing these ideas to those types of discussions, I think will socialize it, because medical people don't really think like this, but they should. And I believe we're in a period of bridging these kind of cultures together for the synergies that we hope will occur to occur. I also think academic medical centers need to open their divisions acknowledge the role that institutes and centers can play to augment more traditional institutes and centers and departments of medicine. I think deans and chancellors need to see that as a necessary step to allow the roots to grow deep and for the mingling to be rich. And I believe in the conversations I've been in that is a widely held view at the kind of dean chancellor level in many institutions already.
Great, thank you. Another question that's come in: to what extent does the global disparity of opinion on the global health system harm One Health efforts?
I think that the discussion of resource expansion is always difficult with any government. We don't have enough money to do what we already say we're doing. And governments are challenged to have 3 more things added to their do list. What allows things to move up or down on that prioritized list for governments is the understanding of where a given area, like One Health, global health, a specific disease as a single disease, where that how that dovetails into the security question, like we talked about, is the biggest move I've seen in government appropriations discussions about global health, One Health, or looking at security issues. And the biggest rise in willingness to see the resource deficit is when you talk about them together. So I think for people who aren't thinking health, security is catalytic in allowing them to better understand the threat. So I would just encourage the medical people to be open to understanding the security language and the way they view threats, to just talk to them better, and vice versa. So I do think there's real synergy there for the greater good, not just to fund something, to do the funding of something that's needed.
All right, thank you. Next question that's come in: could you elaborate on what you mean by using cell phones, movement and purchasing patterns for detection, means, and surveillance, and how would this be implemented?
So in San Francisco, the Bay Area, and then in the last, since maybe Thanksgiving in the state, looking at what people buy, not knowing that it's your credit card, Casey, but just looking at buying patterns, moving from Amazon on the internet to stores and specific sites, reflects a movement pattern that we were able to pick up and see in time changed, and did reflect more interaction, more, and eventually in 2 to 3 weeks, you'd see a bump in number of new cases. And we got so at a local level where we could use that as kind of a surrogate marker of increased activity, increased spread. Let's get ready. The same with purchases. So the same with where the cell phone is location-wise. So we were able to experiment with that a fair amount and saw it as helpful, by no means the definitive anything, just another piece of information that added to our compilation to make an argument for should we open up or not open up? Or are we doing it too quickly? Are people listening to us or not? We also did surveillance on face mask use, just on closed circuit TV, just snapshot counts. And at least we think they were helpful. We'll go that way with it. Yeah.
Thank you. Our next question is over 20% of vertebrate species are traded around the world. How can we act on this problem to prevent the spread of infectious diseases, knowing that this trade is central to cultural traditions, livelihoods, and economic activities for communities around the world?
Well, I think understanding the science of that and then delivering that science to the decision makers and the population who holds the cultural belief. It needs to be real transparent, real aggressive, and continuous. And you'll eventually win that with the, a strategy of kind of local leaders, opinion makers, targeting them to be part of the process, so they become the spokesperson for that, putting those dots together. It's iterative, it's community work. It's not something that governments naturally gravitate to, but I think HIV taught most governments that opening up a dialogue with community changes your ability to identify and retain patients in the long run, and fewer people die. So if you use those as your hard outcomes, I think you can convince people over time. It takes somebody keeping an eye on the ball in a way that is unusual. So I think we need to kind of train those people in ministries of health, in governments, that this type of surveillance is informative and moves your agenda, as opposed to collecting data that is aggregated but never analyzed, which is what 90% of what is going on with global health data collection.
Thank you. The next question is, how can we bring the concept of One Health to the audience of the general public?
I think, when Richard Horton did I'm impressed with, for certain targeted communities, literature works, but it's very limited. And I think a general population strategy of how the one planet, we are all connected, understanding the kind of Venn diagram of ecosystems has got to be what we give to the public in a more comprehensive way. Our educational system is so segmented, stratified, chopped up and cut up and then put back together, that this is one of those themes that should have a reflection in every discipline. And there should be a group that sits down, and a curriculum group, people who develop curriculum. We've all done it for medical things, but you need to get the people who do it for social sciences, as well as English lit, et cetera, and think about what would be a reasonable, not a totally unrelated theme to put in other non kind of health science related topics. I think the general population needs a better understanding of it. Things like Sesame Street at the kind of general population level. Early on in HIV, we used Sesame Street for everything, and it did socialize things differently. I mean, not that it was definitive, but those types. So I think a communications person, really should take this on. Maybe the communications office at CDC, Casey, could actually get a small embellishment to actually hire those types of people from a insurance or from an advertising firm who really do know how you can say something to make it stick better. But I think we vastly underpresent the topic. I mean, it's not like we've tried very hard, is really how I would view it.
Thanks very much, Eric. Next question is, what ideas or policies have been formed to incentivize the sharing of outbreak data on a global scale during pandemics?
It is an area that is of new discussion. I would say very little, if any. I mean, I think uh, the lack of that data, I think, speaks for itself. Uh, I'm not sure what would incentivize a country that is competing on every level for every resource they've got for legitimate unmet needs. And I think it'll be country specific. We need to think with them, and we need to have an ability to do it with them if they can't afford to invest in it themselves. Not for them, with them. And because if we stand up capability that they don't own and operate, we haven't taken the step forward that we need.
Thank you. Next question is, how can the U.S. in its global leadership role encourage open and honest disclosure of outbreaks and diseases of interest in other countries?
I think I think WHO, UN, and others, some foundation people, are in a position to change the way we react. There's still a punitive blame reflex. We saw it in the reaction to COVID. It moved into a political back and forth almost immediately, much to the detriment of really having nothing to do with understanding how we did or didn't get alerted to the outbreak, and going backward into COVID and understanding, were there opportunities to have identified that earlier than we did? And that kind of analysis is not really completed. But I do believe that people are clear that the surveillance system we have needs to be complete, and it's far from it. And that completeness needs to be aggressively mapped. And if we empower WHO to play that role, they are going to still need help from all the major donors to complete it. And instead of it being a critical element to that, standing that capability up, make it a purely we are doing this for all of us to be able to understand how this new threat moves through the population, and whether or not there's a threat to the global population because of it, and how we can contain that. That be the focus of the convening and the discussion. So finger pointing and blame really don't have much of any role there. And if we can't open it up the transparency enough to know when we've got a problem, we'll never be able to catch this. So people have to feel that it's not going to reveal a vulnerability that they're going to be criticized for, or in their mind, punished. And that's a diplomatic back and forth, easily achievable if there's a will to do it.
All right, thank you. The next question is, One Health is not a new concept. For several years, we've been hearing about the concept, but it seems that implementing it is a major challenge. You presented 5 key principles in order to make it operational: multi-sectoral, multidisciplinary, transdisciplinary, accountable, and shared responsibility, which is not easy in middle and low income countries, as it requires lots of commitment from different sectors. So the question is, are there some good examples out there, but they're quite limited? So what, in your view, are the greatest challenges for the wider embracing and rolling out of One Health proactively instead of reactively?
I guess I would say the biggest limitation to achieving a acceptable response is the unwillingness to expand the capabilities that are needed in the country itself. And I mean specifically the government, the Ministry of Health, and civil society. Between those two entities, you really create the core of your response. And everybody else who has input has the ability to either teach or do. They can implement themselves, or they can teach others to implement it. That effort be only on the sharing, expanding the capability in country. So not as you are leaving a program or after you have stood it up, but when you engage with this effort, that it be from day one an effort that is building a capability that is there. Rwanda is a good example of a country that did not allow implementers, multinational NGOs, except for about a year and a half, be the entity that actually implemented standing up of AIDS, TB programs, and they piggybacked their COVID response on those platforms. So that's an example of a country that, because of that self-determination and coordination coming out of their Ministry of Health, and the leadership that has emerged in Rwanda, because they were always positioned to be that entity. So they were always the doer in the equation. They are far ahead of everybody in the region because of that. But that's a good example of just that structural difference in how donors interface with the country and what it creates.
Great. Thank you so much, Dr. Goosby, for your excellent presentation and the great discussion afterwards. We really appreciate you sharing your time and expertise with us.